the UHN sites and Trillium from time to time. And I'm a neurohospitalist primarily, so I do a lot of inpatient time on the general neurology service, but also on the stroke service. And I'm always happy to answer questions that people might have about their patients in any hospital across the province, especially if that patient may have encephalitis and needs subspecialty care. So in the next 20 minutes or so, I'll review some basic aspects of neuroanatomic localization and its value. Hopefully I'll convince you that it's worthwhile. I'll discuss the management of acute seizures, and I'll review the diagnosis of a limbic encephalitis and the various causes.
Hi, I'm the new med. Hi, this is neurology, returning a page. Okay, so just so I understand, you're consulting me because the patient has a brain and you don't understand it. No, that's okay. Not everybody paid attention in med school. That's okay. Yeah, I tell you what, I'll let you know when I'm coming to see the patient. You can join me and I'll show you what a physical exam looks like. Yeah. Oh, and if I see you checking reflexes with a stethoscope, I'm going to beat you to death with it. Yeah, okay. All right, bye. Sorry about that. Oh, it's okay. I'm the new med student. Ah, welcome. Well, we got a couple consults to see this morning. This one is from a doctor who forgot how to take a history, and this one just says MRI is broken. Okay. Well, do you have everything you need? Yep, ready to go. All right, let's go. And don't let other doctors push you around. They hate us because they ain't us.
So unfortunately, I think this is the common and probably more accurate than we'd like to admit stereotype of the neurologist. And I think, unfortunately, there's a lot of chatter on Twitter about reflex hammers and such, including from neurologists that I'm colleagues with and residents in our program. And we'd really like to get away from focusing on little things like that and see things more globally and hope we can be more and more helpful to you all with time. We're generally nice and approachable people, so feel free to ask us questions all the time. So I'll start with a case to kind of guide the discussion. So this is a 78-year-old gentleman who was found outside his home by some bystanders, and he was stuck between the two doors at the front of his apartment building. And his last seen normal time, it was unknown. He came as a code stroke, so that's something we always care about. And then there were some issues with confusion or aphasia, unclear, according to EMS. So he came to the hospital as a code stroke, and his initial stroke scale totaled an NIHSS of 5. So he was not really drowsy. He was able to answer his the month of the year. He was able to close his eyes on command, but didn't follow any other commands, and was kind of speaking nonsensically, and appeared to be inattentive to the right side. So he had an NIH of 5. And then a few more details about his language exam. So when we test aphasia, we try and get people to name both high and low frequency words. So it's much easier to say pen than it is to say hammock or feather, for example, which is why those pictures appear on the stroke card. His speech, he was speaking a lot, but it didn't make any sense. And that's quite typical of a receptive aphasia, so somebody who doesn't understand, and why those strokes are often missed, because people are speaking a lot and it's mistaken for a delirium when really it's a receptive aphasia. And he was only able to follow some very basic, simple commands like close your eyes. He did say his name. So then it gets us into the trifecta of neurology. So is there a neurological problem? If we pass that, then we get to where is the lesion? And then finally, what is the lesion? So it seems like neurologists care about where the lesion is just because it's an exercise that we like to do for no reason. But I can assure you that it does have some value. And probably the most important distinction is separating cortical from subcortical, or what we call lacunar strokes. That has a lot of value in localization and in acute neurology. And then, of course, looking at the anterior versus the posterior circulation. So how about this piece of cortical issues? So we say that people have a cortical problem if they have aphasia, for example, if they have neglect, a gaze preference. That's probably the first thing you'll notice about a stroke patient when they roll in with EMS, is that they're always looking to one side or another if they have a big cortical stroke. And then, of course, a visual field deficit. And then there are things that neurologists test when they're not in an acute setting, apraxia, an inability to do a learned motor task, like show me how you brush your teeth. Prosopagnosia, which is an inability to recognize faces, which actually 10% of the population has in some mild form that they're born with. And Gerstmann syndrome, the most commonly tested neurological syndrome, where people can't make calculations, know right from left, and know different digits. But I'd say, the most important cortical features are aphasia, neglect, and a gaze preference. So we really look for those things early on. So when people have any of those features, we think there's cortical involvement. That's very different from when those are not present and we have a typical lacunar syndrome. So either pure motor weakness, pure sensory weakness, sensory involvement, a combination of sensory and motor involvement. And sometimes we see these interesting but rare syndromes of ataxia and weakness, or slurred speech and a clumsy hand. And any of these syndromes in isolation point to a lacunar or subcortical problem. So a deep problem in the internal capsular basal ganglia. And this is really important because if you see these problems in the absence of one of the cortical deficits, we don't think about a large vessel occlusion. And as you know, those are treated differently in this day and age. And then how about the anterior versus posterior circulation? So the anterior circulation has two primary big arteries. So the middle cerebral artery that causes weakness of the face and the arm and aphasia. And then the anterior cerebral artery that often causes leg weakness and behavioral changes. And then, of course, we have problems with the posterior circulation, of which, the most important for an internist to know is a basilar artery occlusion, which needs to be treated very quickly or leads to death. And interestingly, people with basilar artery occlusions present with an altered mental status and can often have seizure-like movements. So if people are altered and they're not waking up, it's always important to do vascular imaging in addition to a non-contrast CT of the head, because we don't want to miss this diagnosis that can be treated. So back to our case. So our patient had some trouble with language and confusion. And so he had a non-contrast CT of the head. And if you get used to looking at them, we know symmetry is quite important. So here in the left temporal lobe, we see that there is an area of hypodensity, and we don't see it on the other side. So that likely means it's abnormal. And that's not the typical spot we would see in a stroke in. So of course, that means we have to do the thing we like to do most in neurology, which is to get an MRI of the brain. So this patient underwent an MRI of the brain. And you can see here that in the left temporal lobe, there's an area of hyperintensity, so increased signal. It's actually quite swollen compared to the other side. And then on the diffusion weighted images, so the imaging that we usually use for acute stroke, we see that there's brightness here in the thalamus and lining the hippocampus, this nice structure here. And so this is not from stroke. It's something we can see from encephalitis, for example, but something that we often see from seizure. And we can see some of the swelling from seizure too. So it's often hard to know what's the actual cause. So of course, the important thing to do after that is to follow the MRI with an EEG. And take my word for it, there's evidence of a seizure here evolving in the left temporal lobe. So this patient is clearly seizing, is in status actually, and that's why they're having some language difficulty. And so I just wanted to briefly talk about status because I think it's something that interests you guys. This kind of status we worry most about is a generalized tonic-clonic convulsion that persists for a long time, because those are the ones that lead to very bad outcomes for patients. So there are two important time points. There's the 5-minute time point, and after 5 minutes, that's the point at which we think seizures are likely to be prolonged and refractory to treatment. And then there's the 30-minute time point, which is the time after which there really is going to be a long-term consequence. And we used to call status epilepticus seizures that persisted for more than 30 minutes, but this first time point has become more important now because people were waiting to treat patients for a very long time, and that made it more and more challenging to get on top of things. And then there are things that interest us too as neurologists, which are this concept of new refractory status epilepticus. So seizures that don't respond to benzos and a second line agent. And then of course there's super refractory status epilepticus where they don't respond to even, midazolam or propofol. And this is rare, but it does occur. And so this time point definition for status is different dependent on the type of seizure. So like I said, for generalized convulsive seizures, the ones that we're very worried about, it's after about 5 minutes. And then for focal seizures, we worry after more than 10 minutes. And then absent seizures, which we don't see in the adult population at all, are more than 15 minutes. So our patient is in focal non-convulsive status, a very hard diagnosis to make without the use of an EEG. And I just, a very interesting thing for us is this whole thing called NORSE. So new onset refractory status epilepticus. And you'll probably have seen these patients we see in ICUs where we get all excited that they might have an autoimmune cause of their seizures. So these are new prolonged refractory seizures where we can't find an identifiable cause. And there was a nice paper from the French group showing that in 50% of their cohort, we never found the cause. And in 19%, they had an autoimmune encephalitis. And sorry, this is supposed to say paraneoplastic. So 40% of the patients actually had either an autoimmune or paraneoplastic cause. And then there are another 8% that had infectious causes of new onset refractory status. And it's quite important to be able to identify patients that have autoimmune causes of status. So I think you're aware that this NMDA encephalitis is the most common cause of autoimmune encephalitis leading to seizures. And things that separated it from the cryptogenic cohort were patients that had psychiatric changes or memory changes in the time, days to weeks preceding the onset of the seizures, patients who presented with seizures, and signs of inflammation on spinal fluid. So I'll come back to that after. And just to highlight that there is a mortality association with status epilepticus. It's seen up to in 20% of kids and 55% of adults. And again, this is for generalized tonic-clonic status epilepticus. And then, of course, the most important factor in the prognosis is the etiology. So obviously, people who have a anoxic brain injury and SEIS are much more likely to die than people who don't take their anti-seizure medications or have genetic causes of status epilepticus. So time is brain. It's something we always say, and it's important in more than just stroke. It's also important in the seizure world. And so as a result of that, it's really good to have a general approach to the management of status. And I think this is something it's really important for medicine residents too, because there's often a lot of panic when people start seizing on the floor. And that just comes from a discomfort with treating the condition, and that's completely normal. So I always have to, tell our residents, you really need to know doses of medications and just have a preferred agent. And there are various different algorithms, but obviously the first thing is stabilizing the patient, which you're very good at, checking their blood glucose, making sure that we have some IV access, that's critical, and then doing some blood work. And then in terms of options for first line benzos, There was a nice study called the Rampart study that looked at people in the field who came in with status epilepticus and compared giving them IV lorazepam versus IM midazolam. And although IV lorazepam stopped the seizure more quickly, actually the time it takes to open the box and put in an IV, it ended up being that the IM midazolam stopped the seizure sooner. So if you don't have a line, it's best to just give IM midazolam at 10 milligrams. The other issue is we're often underdosing patients with benzos. And so, we want to give 0.1 milligrams per kilogram and give 2 milligrams every few minutes of lorazepam to really get to the goal quickly. And it seems like it might be irrelevant, like which benzo we use, but it really does matter because there's a loss of benzodiazepine receptor sensitivity with time. And so if you wait, takes you, 10 minutes to get the patient their benzo, then they're less likely to respond to it. So it actually does matter. And then in terms of second line agents, there was this nice NEJM paper. It's rare that neurology papers make it into the New England, especially ones about status. So this was a big deal. And it looked at 3 different second line agents. So fosphenytoin, which is easily accessible in most big American centers, valproic acid IV, also accessible, and then IV levetiracetam. And you'll see that the dose that they use for status here is 60 milligrams per kilogram, which is a very big dose compared to what we're using right now. We don't have access to fosphenytoin or valproic acid IV here at St. Mike's, and I don't think they do at many of the sites. Certainly they have fosphenytoin at Sick Kids. The advantage of fosphenytoin is that it can be infused over 10 minutes, unlike IV phenytoin. And so perhaps the comparison between IV levetiracetam and IV phenytoin would not be so similar. But this was a negative study, so all drugs were equivalent and equally safe. So as long as you have one that you want to use, either phenytoin or levetiracetam, and know how to dose it and administer it appropriately, I always tell the residents it doesn't really matter. So over the next 24 hours, our patient was loaded with 4.5 grams of Keppra, and then started on Keppra 500 milligrams BID. And with this, there was a significant improvement in his language. And his EEG showed no further evidence of seizures. And the reason it was repeated because he was not back to baseline yet, which is always concerning to us. And he had some persistent memory difficulties. He could repeat the words, but 2 minutes later, he was no longer able to remember them. And then on further questioning, he told us that he, prior to coming in status, had some episodes where he would feel fearful and have deja vus, which are very typical of temporal lobe seizures. So that's the kind of thing we ask about on history. So we have this patient who has new seizures of unknown reason. He's not at baseline. And whether or not you have an MRI, it means you need to do a lumbar puncture. Really, that's an important thing. Like if you see a patient who's had a seizure and they're not back to normal and enough time has subsided, they need a lumbar puncture. And as long as you've done a CT scan to rule out a mass lesion. I just want to come quickly back to localization. So we know this person has a lesion, and we've identified on history and on the MRI, but especially on history, where the lesion is. I saw this patient in the US, so of course they had an MRI in the emergency department, but we might not have that kind of access here. So we have a patient who had a language problem, who has short-term memory difficulties, and who is having episodes of deja vu and fear. So that clearly points to a temporal lobe problem. And then that really helps us identify what the lesion is. So there's this thing called the limbic system, which is really involving the temporal lobe. So it's this structure here, the memory structure, the hippocampus. And people with problems in that area present with altered mental status, the kinds of seizures we were just talking about, fevers, headaches, psychiatric symptoms and weakness. And that's why people with psychiatric symptoms and seizures, or sometimes even isolated psychiatric symptoms, get referred to neurology by psychiatry, asking us if there's a neurological cause for their psychiatric symptoms. And I think, there are many different kinds of causes of encephalitis. So of course, we're aware of the infectious ones, but very popular now in neurology are the autoimmune and paraneoplastic causes of encephalitis. And I think you'll see that we are always sending these antibody panels. And then of course, there are other causes of encephalopathy with which you're very familiar. And many years ago, there were, it was much easier to identify an infectious cause of encephalitis, but now with time, we've identified many more antibodies, and we're finding a higher prevalence of autoimmune causes of encephalitis. But I'd still say that for you, the most important thing to not forget is HSV encephalitis. So all of these patients need that diagnosis considered, especially because it leads to a lot of mortality and very high morbidity. So people are not confused for 10 days with a normal MRI from HSV encephalitis. It's a very, very bad disease. And the things that are associated with a poor prognosis are being sick before and a delay of admission from admission to administration of a cyclovir. So it's really important to treat people early. So how do we use a cyclovir? So it's 10 milligrams per kilogram 3 times a day. It's important to hydrate patients because it causes a lot of renal dysfunction. So usually that's built into order sets. It certainly is here at St. Mike's. And this limbic encephalitis is important. So when you identify that there's a temporal lobe problem, either on history or imaging, it has a very select number of infections that cause problems there. And it's very different from a rhomboencephalitis or a brainstem encephalitis. And that's why localization matters. It matters in the selection of antimicrobial treatments, of anti-inflammatory treatments, and really in the workup that we do. So causes of infectious limbic encephalitis, HSV1, which is the most common, HSV2, which we do see from time to time, VZV, of course, HHV6, which is important for people who work in a transplant population. There's a proportion of people who develop post-autologous transplant encephalitis. It's often from HHV6. Tick-borne causes of encephalitis, like Lyme, for example, flaviviruses. And then, of course, we can't forget COVID in this day and age, although it's very rare to be associated with a limbic encephalitis. Most bacteria do not cause limbic encephalitis, with the exception of syphilis. However, a rhomboencephalitis or a brainstem encephalitis, listeria is a common cause of that. So see, it really does. We care a lot about pattern recognition in neurology, and these things are actually very important for us. But now on to my main area of interest, which is autoimmune causes of encephalitis. And so if you haven't seen the Netflix movie, which is based on this book, you may want to. It's called Brain on Fire, and it's about Susanna Cahalan's story and the delay in the diagnosis of her NMDA encephalitis. And it's something we actually see more and more these days. So what is an autoimmune encephalitis? So it's people who present with about less than 3 months of memory dysfunction, altered mental status, and psychiatric symptoms, and have to have at least one other thing. So they usually have an abnormal exam, seizures, they'll have a lot of mouth movements, I'll show you in a second. And then we like to see signs of inflammation in the brain, or an MRI suggestive of encephalitis. And then, of course, we need to rule out other things, especially that HSV encephalitis. So this is an example. The prominent movements of the tongue and the mouth are very common in these autoimmune causes of encephalitis. I hope this one will work.
This patient with anti-NMDA receptor encephalitis is seen in an intensive care unit setting.
So the movements around the mouth are very typical, and they often need a bite guard because They get
Rhythmic,
severe bruxism and bite down on
facial,
things.
chewing
And you,
movements.
as soon as you see this, you know this person has NMDA encephalitis. It's extremely common. I wrote to our admitting service yesterday and
This
told them I
patient-
had to transfer a patient from Barrie who smelled of NMDA encephalitis because I saw her on Zoom in her hospital bed and she was making those mouth movements. So they're very typical, something we really need to look out for. So how do we investigate for an autoimmune encephalitis? Of course, we do our favorite thing, the MRI. But I should say that in 50% of cases, the MRI is normal. So it's not because you have a normal MRI that it excludes the diagnosis. And I have a number of patients who have NMDA who had normal MRIs over the entire course of their disease. EEGs are important. Some of the different antibodies have a specific electrographic signature. It's also important to make sure that they're not in status. And then spinal fluid testing. Spinal fluid testing is very important, and it's actually something, that we need to do better. We often send a cell count, but that's not the only marker of inflammation. So sending these two things, IgG index and oligoclonal bands, are extremely important. There are other markers of inflammation. So unlike an infectious encephalitis, the number of white blood cells on an autoimmune patient can be normal, and we can see, unique oligoclonal bands, so markers of inflammatory proteins in the spinal fluid that, when compared to the serum, are much higher in the CSF. And then I just want to highlight that HSV, although it is an incredibly sensitive PCR early on, like within the first few days, doesn't have a perfect sensitivity. And so if you're highly suspicious of that diagnosis, it's important to repeat the TAP. It remains positive for a period of 2 weeks. So there's no reason to not start a cycle while you're waiting for it to come back. And then with respect to varicella, the PCR is less sensitive than the immunoglobulin in cases of encephalitis and myelitis. So it's important to send IgG both on serum and CSF to look at the ratio, and also an IgM. And then in terms of the panels, we have to be careful when we send panels. It's good to have neurology involved. If you're thinking about autoimmune cases, there's a lot of false positives at low titers. So it's best not to just randomly send panels, because it leads to more having to follow up on low titers in delirious patients. And we want to try and avoid that. So back to my patient, he had repeated spinal fluid testing with no inflammation. So normal white blood cell counts, no oligoclonal bands, and repeated PCRs that were negative, flow and cytology, and the panels were negative at the Mayo Clinic. And so in the absence of inflammation, he eventually underwent a brain biopsy, which revealed a high-grade glioma in the temporal lobe. And so I think I've unfortunately seen that at least 5 times in the last few years. So something to look out for. So that's all I really want to say. Localization is helpful to us, but so is the MRI, and both are because we use pattern recognition to try and help us find out the etiology. As internists, it's really helpful if you think of to send these other markers of inflammation, the bands and the index, and we really also obsess over opening pressures, but we can come to that at another point. And then in the absence of signs of inflammation, we would always consider non-inflammatory causes. It's not because people have enhancement on their MRI that they have an inflammatory disease. Strokes have inflammation, have gadolinium enhancement. Tumors have gadolinium enhancement, and they're not inflammatory problems. And then know a second line agent that you like using, and know its dose. That's all I really had to say. Happy to answer any questions.
Thank you so much. That was not the conclusion that I think most of us were expecting. Billy says, curious as to your perspective on the role of EEG for inpatients. They often are ordered when they seize at home but are back to baseline. Is it useful to pursue if they're back to baseline?
So that's a very good question. So I would say that an EEG is not useful if you know the patient seized and that they're back to baseline. Unless they've had a generalized tonic-clonic seizure, and in a young patient, we're looking for a signature of a kind of genetic problem. I don't know that it's worth it to keep a patient in hospital to get an EEG. The caveat to that is if you have a patient who's confused, or you're not sure if they had a seizure, they had some kind of event, the EEG is more sensitive if it's done in close time relationship to the event. So if we're consulted on a patient that may have had a seizure, then I try and get it as an inpatient. But it's often not discharge limiting, certainly not if the patient is back to baseline.
And
Also, it's a bad test. It has a sensitivity of about 30%. So if you do a bad test several times, like CSF, AFB, or cytology, you increase the sensitivity significantly. So the sensitivity of 3 EEGs is closer to 80% in identifying a person that has had a seizure or electrographic abnormalities.
so I have lots of questions. I'm just cognizant of the time, so I'm going to move on to Alina. But if Rodrigo and Mike can type your questions in the chat, maybe Alex, you can answer them there. That would be great.
Sure.
Recognizing we had a bit of technical difficulties. So we're going to move on to Dr. Alina Blazer, who's a respirologist newly hired at UHN Sinai as a CQI. She completed both her residency fellowship and then an asthma and airways fellowship at the University of Toronto, and is currently pursuing her master's in clinical epidemiology at UT. Her research interests are broad, but she does have a specific interest in the overlap of COPD and women's health as well. So Alina, I'll let you take it over, and Alex, if you don't mind answering the question, that's great. Thank you so much. That was amazing.
Great talk, Alex. I'm just going to ask if you don't mind stop sharing your slides, and then
Sorry, I'm just
no, it's all good. It's all good. Awesome. Okay. So thanks, Allison, for that introduction. It's my pleasure to be here. We're going to shift gears wildly from the brain to the lungs. And I'm going to talk about something that I'm really passionate about, which is changing how we look at COPD and focusing on the recent GOLD recommendation update. I have no financial disclosures. And so the quick objectives will be to review some of the key takeaways from the recent guidelines and sort of understand the rationale for these updates. Okay, so just really briefly on COPD epidemiology, because I think sometimes we forget the massive burden that COPD really is in our society. So about, this slide from ICES is a little bit old now. However, these prevalence values haven't changed too much. But about 1 in 9 Ontario adults lives with COPD, with a prevalence here in the province of about 11%. And in Canada, the kind of nationwide prevalence is about 10% of the adult population, over 2 million Canadians. And COPD exacerbations, therefore, form a significant burden on our healthcare systems and are really the second leading cause of admission, only behind labor and delivery nationwide. Globally, COPD is also a health crisis, affecting more than 300 million people and accounting for over 3 million deaths, or the third leading cause of death worldwide, back in 2019 when the WHO last updated these statistics. This is also significantly underdiagnosed in certain places, just in regards to access to resources and recognition of symptoms in patients. So certainly something that is very prevalent and a burden worldwide. Okay, so from there was launched something called the Global Initiative for Chronic Obstructive Lung Disease, or shortened to GOLD, somehow using these various letters. And this was launched over 25 years ago, and their goal was really to develop COPD management and prevention strategies that all countries could kind of read and then implement as guidelines within their own healthcare systems. To do this, they come out with an annual report. And again, they're careful to call it like strategies and not true guidelines, because again, they expect individual nations and clinical societies to kind of use these as recommendations in forming their own guidelines that work within their own health system. So there have been some years where the GOLD guideline, or recommendations rather, don't change very much. However, the 2023 report, which came out in November of 2022, so it sort of comes out for the preceding year, definitely had some major revisions that really represent a shakeup in how we should be thinking about COPD. And so I'd like to go through some of the kind of major changes that happened. So one is a new sort of definition or how we define various types of COPD. The second would be how we approach diagnosis and some new terms to kind of be cognizant of. And the third, although sort of less dramatic, but yet important, some small updates in the management of COPD. Okay, so to provide a little bit of background though, I think many of us who maybe grew up with textbooks still might have seen these pictures from Netters of what COPD has historically been thought to look like, the pink puffer and the blue bloater. And we've certainly considered COPD to be this self-inflicted disease in older males who smoke. However, for many years, we've known not all smokers develop COPD. And there's a significant proportion of COPD that occurs in non-smoking individuals. And so in this graph here on the x-axis are different epidemiological studies done in different countries or geographical regions worldwide. And along the y-axis, I recognize it's small, but that's the proportion of patients identified in that epidemiological study who had COPD and were non or never smokers. And so as you can see, the percentages range wildly, but can be upwards of 20%, across these studies, sometimes as high as 30 or 40% of COPD occurring in non-smokers. So taken together, these have led to a growing recognition that COPD is not just a disease of smokers, but it's something that comes from multiple risk factors, and that it can even begin in early life or even in utero. And I'll kind of delve into this a little bit more. So this graph has actually been in the GOLD recommendations for a couple of years, but I feel like respirologists are the only ones that have paid attention to it. But I'll just walk you through it. On the x-axis, we have age, and on the y-axis, we have FEV1%. And so most people, when they're born, their lungs continue to develop up until about your mid-20s. And so you're under optimal conditions, you end up at this place here where you've attained 100% of your FEV1 that's predicted for you, so your maximal attainable lung function. After about our 30s, we actually all lose lung function on a yearly basis. And so our lung function declines as we age. So you end up lower than where you started, but not in a place of COPD. And that's this green curve at the top. If this individual were to say start smoking or have various occupational exposures that place them at risk, they might develop accelerated lung function decline and instead follow this red slope where they end up in sort of the classic COPD that we all think of. However, there's growing recognition that there's many individuals in the world, again, that 20–30% of folks who really never achieve their full lung function potential during their life course. And there are various risk factors that contribute to this. And so say you end up here in a place of 70–80% of your maximally attainable lung function. You're not diseased and you lose lung function over time, just as the green curve. So you end up lower, but again, not technically meeting criteria for COPD. But you can imagine that for this individual, should they also smoke or have other exposures that place them at risk, it doesn't take as much lung function to lose to get to a place where you would have chronic obstructive pulmonary disease. And this kind of mismatch between the airway caliber and size and your lung function is a term that we use called dysynapsis. Okay, so what are some of these risk factors? And there have been a lot of studies that have tried to contribute to this. And again, really thinking of this as something that occurs over the lifespan. And so in even preconception and in utero life, maternal exposures, maternal smoking might play a risk in terms of lung function and development. We know that prematurity and intrauterine growth restriction are also risk factors for that dysynapsis or low lung size later in life. In childhood, chronic asthma, infections, especially TB, and then ongoing exposures outside. So in terms of air pollution, biomass fuel in developing countries, environmental tobacco smoke, all of these things contribute to that lower attainable lung function. And then of course in adulthood, those same kind of risk factors continue, including uncontrolled asthma, smoking, HIV, and other occupational risk factors. And so taking all these things together, the GOLD has put together a new definition of COPD. And so this definition that they put sounds kind of like the COPD that we all know. So a lung condition with chronic respiratory symptoms, with abnormalities in the airways or the alveoli causing symptoms. However, the key kind of important word is this heterogeneous lung condition. And they actually take a step further and now divide COPD into various types. That really stemmed, and I think is well depicted in this diagram, which was this really landmark paper that came out a few months before the GOLD guidelines. And it was this Lancet commission focusing on the elimination of COPD. This is really an excellent paper, kind of really trying to shake up the way that we view and research COPD. And so they divide COPD into 5 categories now. So type 1 being genetic causes, type 2 being early life events that we sort of just discussed, type 3 being infectious, type 4 being smoking and environmental tobacco smoke, which they really mean secondhand smoke exposure, and then type 5 being other environmental and occupational risk factors. And the GOLD guidelines have taken this and classified COPD into these various types based on that diagram that we just saw. Both groups recognize that this is imperfect and that these things might evolve and change over time. But this is really, as I said, meant to represent a shakeup in how we think about COPD, in the risk factors we consider, and hopes to drive further research in preventing COPD, intervening earlier in life, and coming up with new therapeutics other than just like the same inhalers that we use continuously, but things that can actually, slow lung function decline, reverse existing damage, etc. Okay. And I have to say, as someone whose master's is on non-smoking related COPD and got some like pretty big eyebrow raises when I proposed that as a topic, it's kind of cool to see this making it into the mainstream. All right, so moving a little bit away from how we define and view COPD into how we diagnose. So the current diagnostic criteria, as we all know, is non-fully reversible airflow limitation as defined by an FEV1 to FVC ratio less than 0.7 measured by spirometry. And respirologists have been up on our soapbox, banging the drum of everyone needs to get spirometry for a diagnosis. And I don't want to take away from spirometry, but we do need to move towards other ways of diagnosing COPD if we want to detect it earlier on. And so some of the problems with spirometry is that it really is a very overly simplified view of what's going on in the airways. We've known for a while that spirometry values are a poor predictor of symptoms and quality of life. We have all seen patients who have very severe impairment on spirometry but don't perceive any symptoms, and the converse can also be true. We know that there are individuals who have respiratory symptoms, structural, physiological abnormalities, and have no overt airflow obstruction. And really, if we're defining COPD, chronic obstructive pulmonary disease, by irreversible airflow obstruction, that really precludes the diagnosis of early disease from all those risk factors we just talked about. And so, currently we're in a place of A in this diagram, where lung function is declining, symptoms are increasing, but we're only really diagnosing COPD at a point that it's sort of irreversible and fixed. What the goal would be is to come up with ways to diagnose COPD at this point, where lung function is starting to decline, symptoms have not really ramped up yet, and that we can actually intervene in the disease state and hopefully prevent things from becoming worse. Okay. To do so, though, we have to find some right terms, and the literature is rife with all sorts of confusing terms such as early, mild COPD, young COPD. And so the GOLD guidelines have also attempted to kind of define some of these things. And so early COPD, with early really meaning near the beginning of a process, is probably the trickiest to really pinpoint, especially if we believe that COPD is something that begins much earlier on than we previously expected based on all those risk factors. And so the goal with using the word early COPD would be to focus on a biological early as opposed to a clinical early or a mild airflow obstruction. And they really say that the word mild should also be used to represent severity on spirometry and not as a form of defining the disease. They also bring back this definition of pre-COPD. And so some of you may remember a number of years ago, there was a gold 0 category in the previous gold divisions of lung function impairment. And those were individuals who had respiratory symptoms and perhaps other structural or functional abnormalities, such as on imaging, but they had an absence of airflow obstruction on spirometry. This category was previously removed, mainly because some of them would go on to develop COPD, but many would not. And so no one really knew what to do with these individuals. But again, with this new emphasis on case finding earlier on intervening early, they brought back this concept of pre-COPD. And finally, they defined something that we as respirologists have seen for a while, having to interpret PFTs, but this concept of PRISM, or preserved ratio, but impaired spirometry. And so those are folks who have an FEV1 to FVC that's greater than 0.7, so technically no airflow obstruction, but their FEV1 is low. However, this is in the absence of true restrictions. They would have a normal TLC. This is not uncommonly seen in current and former smokers. There have been some epidemiological studies on these patients and suggest that they do have increased mortality. But it's also not a stable phenotype. So, repeat spirometry in these individuals can also transition to normal and obstructed spirometry over time. And so again, knowing how to treat and categorize these individuals has been a challenge. But GOLD is attempting to kind of define them so we can study these groups. I think one of the challenges with these groups could be that spirometry, as I said, is really imperfect and can't really get at those, earlier, smaller changes in the airways. And so the Lancet Commission actually came up with this new diagnostic algorithm where they moved beyond spirometry and how we diagnose COPD. They also recognize that spirometry is not always readily available, but sometimes things like imaging, especially with CT, are. And so they would suggest, if you have PFTs, they're less than 0.7, great, you've made your diagnosis. But if you don't, consider things like imaging and seeing emphysema, air trapping, other airway abnormalities in a patient with the right, clinical symptoms and presentation, that counts as a diagnosis. Or if you do PFTs, but they don't quite meet criteria, consider other alternative testing techniques. And some of these are coming, things like oscillation. And if those things are abnormal, then they could also need a diagnosis of COPD. Now, the latest GOLD guidelines don't quite go as far as adopting this algorithm. They do have a new section on what the role of CT is, but they, still mainly use it for things like looking at other differential diagnoses and, of course, lung cancer screening. But as a respirologist, I really like this new kind of concept of diagnosing COPD beyond just classic spirometry. Okay, so briefly, just focusing on updates in management. So, I think many of us are probably familiar with this previous image from the GOLD recommendations, where they lump people into 4 categories based on symptoms. That would be along this x-axis at the bottom, and exacerbations along the y-axis here. So patients that are unsymptomatic, not really exacerbating, a bronchodilator, those with lots of symptoms and exacerbations would receive some kind of additional therapy up here. So in the 2023 guidelines, there's been a few changes, and we'll just go through these really quickly in the last few minutes. So to start with kind of one of the easier changes, in the group B category, which previously they said you could use a single bronchodilator, they've upgraded this to starting patients on dual bronchodilation upfront. This stems predominantly from this trial, which was looking at the EMAX trial, so early maximization of bronchodilation in COPD. And this looked at exactly those group B patients, so symptomatic, but with low history of exacerbations. And they found that starting dual bronchodilation provided improved lung function parameters, improvement in symptoms, and reduction in treatment failure and exacerbation. Okay, and how does this align with our current Canadian guidelines? So our current Canadian guidelines would suggest that the group B group would be this sort of yellow column here, and that perhaps we should be bypassing that bit where we just give them a single bronchodilator and start them with dual bronchodilation up front. The other big shakeup is that instead of being A, B, C, D, they now are A, B, E. And this is mainly moving away from a place where people with low symptoms but exacerbations were previously group C, and that wasn't really a very clinically relevant group. Like exacerbations by definition have symptoms, so how does that group really get defined? And this is also emphasizing the importance of exacerbations as a sort of critical step in COPD patients' sort of lifespan. And so in these folks, they would also suggest starting with dual bronchodilator therapy upfront and considering triple therapy in a certain group of patients. So importantly, you no longer see inhaled corticosteroids anywhere up front in the sort of COPD algorithm, except in people that are in this sort of severe group who mainly meet certain criteria. So while this fuss about sort of inhaled corticosteroids, so there's been a long, Meyer Balcher described it as a long winding road of ICS and COPD, and I would agree with that. Studies have gone back and forth on their utility. But the major concern is the risk of repeated pneumonia events seen in patients that are treated with inhaled corticosteroids. And so the individuals that we would consider ICS in are those who are having many hospitalizations and exacerbations of COPD. Certainly those who have blood eosinophils greater than 300, this has sort of been a persistent signal that they might benefit from inhaled corticosteroids. And of course, those who have a concomitant history of asthma need the ICS to treat the underlying asthma as well. Interestingly, we now actually have 2 studies where they looked at triple therapy and mortality in COPD. Those were called IMPACT and ETHOS, which looked at single inhalers that had triple medications within them and had mortality as a pre-specified secondary endpoint and had positive findings. And so, we certainly, if a patient needs an ICS, we would just consider starting it as a triple therapy upfront instead of ever really going to that ICS LABA as a first line. Okay, so how does this align with the Canadian guidelines? Well, we never really had a group C, so the fact that that's gone, it actually aligns with our guidelines perfectly. But otherwise, we would suggest that, again, there's really no role for ever starting ICS LABA up front. Either start dual, or if you feel they would benefit from inhaled corticosteroids, just start with triple. The GOLD guidelines also suggest that if you can do this using a single inhaler that combines all 3, there are studies that suggest that in terms of adherence and outcomes, that's probably favorable. Okay, and just, I guess, in the last minute, as a quick touch point about exacerbations, we used to define those as whether they're moderate or severe, depending on where they received therapy and what kind of therapy they received. So moderate exacerbations were ones where people got a steroid or an antibiotic but didn't have to be admitted. Severe exacerbations were those requiring an admission. But again, people felt that this wasn't really, a valid way of describing the severity of an exacerbation, as there might be regional differences in who gets admitted and how they get treated. And so there, in the latest guidelines, there's been this change of classifying severity of COPD exacerbations by actual clinical parameters. And I think we can imagine that this all makes a lot of logical sense. And so mild exacerbations would be patients who are essentially, pretty vitally stable, with, of course, severe exacerbations being individuals who have, alterations in their vitals, hypercapnia, et cetera. Okay, so I know that was a bit of a whirlwind, but in terms of the key takeaways, I think it's important to remember and critical to how we think about COPD going forward from here. This is not just a disease of older men who smoke. It is heterogeneous. It requires a broader understanding of risk factors. And I think you're going to see a real push towards understanding these other types of COPDs and new therapies for those individuals in the coming years. The earlier we can diagnose things, the better. So there's an emphasis now on early biological changes and how we diagnose these folks. And then finally, I think the third point would be that 2 or 3 medicines in one is better than just one. And so starting dual or triple inhalers up front in patients who are symptomatic and exacerbating is probably beneficial. Okay, and with that, I'm happy to take any questions and field any COPD emails in the coming years.
Thank you so much, Alina. That was a great overview of things that just came out not that many months ago. So I think I only learned about this through you back in December. So, yes, as Shifra noted, the gold guidelines has both pocketbooks that are available online, and there's also teaching slides if you want to review them. Don Redelmeyer says, any comment on gas burning indoor kitchen stoves? Hot topic.
Yeah, so I think there's been some evidence about gas stoves and risks of asthma, especially in children. Probably less information on that and COPD. However, as I said, childhood asthma, especially uncontrolled asthma, is certainly a risk for fixed obstruction and remodeling later in life, which is probably its own sort of etiotype of COPD. Otherwise, worldwide, we definitely know that wood burning stoves, cooking with biomass fuel, poor ventilation, those types of indoor air pollution exposures are certainly risk factors for COPD.
And we'll leave this as the last question. Steve Shadowitz asks, is there a reason to choose one LABA or LAMA over the other, recognizing the many, many puffers that we have options for?
No, so I mean, there's been in the past some evidence that LAMAs, if you're choosing a single bronchodilator, might have some incremental benefit over a LABA as a single bronchodilator in terms of exacerbations. But in terms of the actual drug, from my perspective, it comes down way more to what can the patient adequately use and what they can adhere to. And so, the difference between, there's been a push recently for dry powder inhalers, almost from an environmental perspective. But if patients can't take that sort of more forceful inhalation, they're not going to get the benefit of it. And so when it comes down to an inhaler or drug choice, for me, it often becomes a question of inhaler, device, technique, and adherence.
Thank you again to both of our speakers. That was really great. And thank you to our audience for adapting to the new Zoom link. If people are able to fill out the evaluation for the session, that would be great. As always, any ideas, thoughts, or comments are welcome. And if you want to recommend these talks to other people, they're always available on our GOM website for review in an asynchronous nature. So thank you again for your extra 5 minutes. I really appreciate it. And hopefully we'll see you guys in a month.